First of all, I would like to thank all of you, all the organizers, for giving us the chance to introduce ALS in Indonesia, and of course, including us in this wonderful collaboration. So I'm really, really hopeful that out of this, a lot of better understanding and support would be uh, felt by all of us. So I will introduce to you the Indonesian community. It's a very small community in which some of the ALS patients, or MND known in other countries, and their caregivers, the doctors, and also the families are friends who have concern on how ALS patients are trying to cope with their condition and also try to continue having life of good quality. I'll try to be very brief. So, as in other countries, ALS or MND patients are hard to identify, and that requires a lot of collaboration, in particular with doctors of various specialties. As you know, um, the symptoms don't necessarily start with something that immediately recognizes of neurological problems. So some of them would go to ENT specialists, some other would go to food specialists because they've got problems walking and that sort of things. So depending on the level of the healthcare system in the region, uh, the patient might be sent to eventually the right specialist with the neurologist, but most of the time, or we suspect most of the uh, patients are not yet diagnosed because they haven't reached the correct doctor. So as of recently, this is the distribution of MND or ALS patients in Indonesia, meaning they have been diagnosed and they have, one way or the other, contacted us at the foundation, so we put them in our list of patients with ALS. The number that I quoted down here is an international statistics where you can see the incidence and prevalence of ALS patients. You see that even though it's considered as a rare disease, but if you got a large number of populations such as Indonesia, and then if you just count those who have older than say 50 years, you still have more than 100 million people in Indonesia. So you got a pretty high number of guests that you could have in Indonesia. So therefore, we only have a number of dozens right now. It's not even 100. So we were wondering where are the rest and how are they doing, and all those sort of questions. So in 2015, we started to have the first public seminar on ALS with the motivation to introduce ALS to a larger audience, including those among medical professionals, because it is rather obvious that even within the professionals, ALS or MND is still not well known. So therefore, the pipeline for identifying patients has to really start with medical professionals. And we've been very, very fortunate to have the support and continuous beautiful support from my Pada Hospital in South Jakarta, who provide us with office and meeting rooms whenever we are gathering. So we haven't been back then since probably beginning of January before the COVID thing started. But since then, the good thing was um, uh, uh, newspaper, magazine, etc. I've been picking up ALS or MND and putting those among the things that they try to help us by introducing the issue to the public at large. And one of the nice, well, I don't, maybe nice is not the right word, but having celebrities as sample of ALS or MND patients, such as Professor Stephen Hawking, helped really a lot. So when the movie about him came out in 2015, we got a nice free viewing provided by At America, a part of the United States Embassy in Indonesia. So everything uh, blasted up from there. Even though the movie wasn't shown in commercial theaters, but a lot of people got to know this movie because it won Oscar, etc. But more importantly, people suddenly feel connected, and then there are also the the ice bucket thing. So there are many things that suddenly went uh, on regarding MND or ALS around the world, and Indonesia benefited from that, obviously. So in the same year, we established our foundation, and we realized that we are not uh, a collection of experts just yet, but it's a growing uh, number of people in there, but mostly patients and caregivers. So we understand that from day one, our concentration is not on the technical issues, but it's more on the caring and the humanitarian aspect of it. But nonetheless, of course, the technical part of the medical care is something that we pursue by working together with doctors and again with a number of hospitals such as Mayapada. And I've been extremely fortunate to have help from uh, friends. One of them, Alice, who's here with us, um, uh, who has been caring for family members who had MNDs or ALS, and also Dr. Sheila, who's been tremendously helpful in putting things together and developing. She's our home neurologist, but more than that, she's somebody who's holding the torch of our um, ALS community. Um, our foundation is very simple. Uh, our main objective is to make people with ALS and their caregiver know that they're not alone. So we try as much as we can to provide a communication platform, and it could be anything using electronics. Of course, that's the main thing. In our WhatsApp group, we've got 120 something members of patients, caregivers, and caregivers who have lost their loved ones to ALS. They're still with us. So it's just a lovely, lovely family. And again, as I mentioned, what we like is just for people to not feel alone, and they could share their grievances, they could share their success stories while caring for their loved ones, and those things are documented. So meaning those are not just chit chat that people listen and pass, but it's something that we document. So therefore, it's a learning process for all the patients, the caregivers, and also the medical professional who are among us in this endeavor. We also try, although not uh, in a successful just yet, to do fundraising, more awareness raising, but we're there and we've been offered assistance, but we need to just uh, have a better management and organization. But I hope with this um, collaboration, we will learn a lot from you on how to do just that. But the other thing that we learned that became a part of our uh, sort of responsibility is just every now and then, one or two of our fellow patients would have to go through emergency situation, and it's good that we uh, put together a coordination on how to help them. Different situations require different responses, so it's good to be able to know where to go and who to talk, and it's the other thing is it's good to know that in general people are ready to help as long as they know what is it that is needed. But that's often the case. We don't know what we need. So with all this sharing, we we extract uh, the the important things that are common uh, necessity among ALS patients. So here are some pictures of our routine meetings. There are more and more of us, but also we've been losing quite a number. So it's about almost balanced. We gain about 6 new friends per year, and we lost about 3 to 4 per year, something like that. And we got to uh, be part of a larger network, which I will show later. Among those is the ALS Therapy Development Institute, and some of them are pretty well-known celebrity, like this person who really made the ice bucket challenge a huge success. Um, it's something that I like to, because this afternoon more are ALS patients or and the caregivers, um, especially us in Asia or in Indonesia, and something that I know of. Um, uh, Accepting something that is befallen you can be done or can manifest various ways. So what I like to emphasize here is that what is the difference between accepting and giving up? Accepting, as I mentioned here, is just you try to continue the best you can with any given living condition. And that often means, you're asking what is your main life principle, because you've got practical constraint, which is progressing. So accepting meaning you need to know what would be the best strategy. One of them is staying positive and empower your rational thinking. And one of the magic thing about ALS or MND is most of the time your mind stay intact. That could be something which is challenging. That could be something which is uh, a blessing. It depends on how you take it. If you cannot do anything, but you can still think, you know, I don't know whether you might as well think, well, I might as well be gone, or you use your still very powerful thinking to do something, to stay uh, in participation. So it is a very it's a very hard challenge to have your life cut short, in the sense that it is not a matter of life and death, meaning that your participation in active life is cut short because of your new living condition. But how are you going to keep that alive, meaning your participation alive? You need to have strategy, and or your caregiver need to understand that strategy. So I think this is something which is perhaps unique in the MND or ALS patients, because each person has different prognosis. So you don't know how much time is ahead of you until the very late. So, but on the other hand, you need to prepare, because uh, how your future life, uh, the quality of it depend on how good you prepare for it. So therefore, decision making, etc., is something which is we learn all the time, and it changes with time because the disease itself is progressive. So with that, there are always a good positive side of everything. There's, they say, silver lining around the dark clouds. So here are events that keep our motivation alive, keep our positive attitude alive, getting together, sharing, socializing, learning from each other, praying for one another, and getting support from those who don't have anybody actually afflicted in the family, but still they like to support. So that's a really humbling experience for me as a patient, and also as a person who run this foundation. It's just amazing how we learn that people are so easy to support. Um, what we do, as I mentioned before, with our events, our sharing, we try to put together things in documentation. It could be in forms of brochure, videos, book that Dr. Lo and Dr. Sheila put together beautifully, and we make it easily accessible for people. And we have Facebook, Instagram, YouTube, anything that easy for them to access, with people with a different condition use different gadgets, but we try to be friendly to all. But of course, we are still learning. So these are the samples of our products that we're still improving, is obviously, and these are the network that we are trying to be part of. Of course, this gathering that we're here now, but also we're having the support of the Indonesian Neurologists Association, the PACTALS, the International Alliance, and the LSTDI that I had mentioned before, and the universities that provide um, training, etc., to our doctors. We owe all of them really a lot. So I think I'll end here. So thank you very, very much, and I look forward to learning from you. Thank you.
Yeah, without much further ado, I shall start. So I'm grateful to be here. I shared with some friends that we are very indebted to Dr. Loh Chin because when we visited KL 2 or 3 years ago, I can't remember when, to participate in the teaching organized by UM, um, some of us were at the valley, at the bottom, low end of our morale because we were facing uphill struggles with financing the program in Singapore. And I remember during a bus ride, Dr. Loh spoke to me, and at the end of the bus ride, I was energetic and ready to fight again. So, just a bit of sharing. So, we are the small island at the southern tip of the Malaya Peninsula, very, very small. This is the founder of our hospital. This is my present hospital. And like I mentioned in the morning talk, you only see the Tan Tock Seng logo here, but actually there is a co-house in this building is the National Neuroscience Institute. So NNI started in before the year 2000 together with Tan Tock Seng in the same building, and then it has become a national institute. So now NNI covers all the most of the public hospitals in Singapore, and they are like a network with expertise in stroke, in various neurological conditions. But we were very fortunate in Tan Tock Seng to collaborate with NNI right from the start because this has given us a chance to work with with many ALS patients all over Singapore. And to this day, my team is like the Siamese twin of the NNI neuromuscular team. So we work together very closely. We have got multiple work chats, and we are good friends personally. So I think Dr. Josiah is hiding in the corner in the audience. He will correct me, and he will answer all your questions about neurology. Okay, this is my inspiration, Dr. Bjorn Ibsen. He's a Danish anesthetist. So you all may not know, but I'm an anesthetist and intensive care doctor. So like Dr. Bjorn Ibsen, we started out looking after people with breathing insufficiency in the ICU. So in his case, it was a polio epidemic that swept through Europe. And in Denmark in the 1950s, they ran out of iron lungs. So in those days, the breathing machine was a box. You lie inside the box, there's a vacuum around your chest, and it sucks the air in. And they ran out of the iron lungs, and patients were dying. So he very innovatively arranged for tracheostomy for the polio patients. And they didn't have Philips or Brias or ResMed in those days. They had hands. So got medical students to line up in 3 shifts to do hand ventilation, right? And with that, they saved the lives of thousands of polio patients in Denmark. Of course, the whole story of home ventilation is how, after these lives were saved, they were left languishing in hospitals, or in some countries they decanted as if we are wine, right? We are people, we are not wine. But these people were decanted to community hospitals or nursing homes and left dependent on machines in these places. And the beautiful story of home ventilation is that it is the rebellion of the patients and the rebellion of their friends and family who refuse to accept that you have to be trapped inside hospital four walls. So in France, it was the association of the friends of the people with polio that started in Lyon. They started by taking patients with polio on weekend home leave and showed that they could keep the patient alive. So Friday night, they take the patient home or back to the beach or something. Then on Monday, the patient check into the polio hospital again. So from there, it took another 10 to 15 years, both in France, England, and other European countries, before the governments recognized that there is a right for the polio patients to stay at home and to be supported by doctors and nurses in those countries, in their own homes. Of course, in Europe, because it's a kind of like a socialized medicine, social welfare kind of system, there are good and bad points about it. The good is that the government kind of supports most of their needs. So access to healthcare, access to essential equipment, access to visits. are all in the pipeline. Once you are recognized, a doctor certifies that you have a disease, then you get access to all this. The bad is that being socialized medicine with limited finances, especially in an economic downturn, what do people do? They try to cut. Okay, so imagine that you have you have access to someone coming to reposition you or turn you 5 times a day. But if let's say during an economic downturn, the government decides to cut down and you only have access to that person 3 times a day, suddenly your life is turned upside down. Of course, in Singapore and in Asia, we don't have this kind of socialized health together with social support. We have to depend on ourselves, depend on our families, and depend on one another. And again, I'd like here to express my thanks to MND Malaysia and to ALS Indonesia, because it's so beautiful to see the energy, the commitment, and the compassion of the people. So both patients helping themselves, patients helping one another, family members who are not exhausted just looking after their loved ones with ALS, but family members who also look out for each other's families. So it's so beautiful, and I'm privileged to be able to share a little bit here. So the scope of today, this being the introduction to the series, actually, I thought that I was supposed to talk about all these in general terms. Of course, I'm not qualified to talk about most of these because I'm only specializing in anesthesia and intensive care. But I think the organizers have planned a very good program over the next few months, and we'll get through all this. So very briefly, essentially what will, let's say if I were to present with weakness or with a change of voice, and I think I might have ALS, what do I need? So I think you start with needing to make the correct diagnosis. Dr. Premana mentioned how actually this is a problem because the patient may present to different doctors, to a GP, to different specialists. And it's important that the whole community of healthcare professionals are aware of the needs of people with rare diseases. But then as patients, hopefully the patients are also aware and very ready to challenge their doctors if the doctors neglect to think about this, and then to ask questions nicely and request nicely to be referred to the correct specialist. Okay, so I think we, as patients and family, keep yourself informed. So there's a lot of good information out on the internet. There's also a lot of rubbish on the internet. Go to the reliable sites. So I'm sure like MND Malaysia, ALS Indonesia, and the reputable public hospitals or universities all will have links to good information. So make good use of them. Okay, but once the diagnosis is made, then we need to see whether there are ways to delay the progression of the disease. Currently, quite sad that there are not many good medications. There are some medications, but not terribly good, that can delay the progression. Then after that, you can see the rest of them are all supportive treatment. So breathing support. So under breathing, I'll include breathing and clearing the airway of secretions. Secretions a bit complicated because there are lung secretions, there's also saliva. Okay, then there's nutritional support. So one of the problems with ALS is that it affects the throat. And we breathe through our nose, we eat through our mouth, air goes from your nose into your lungs, food goes from your mouth into your stomach, and then hopefully we don't vomit. But when we cough and there's phlegm comes from our lungs out to the mouth. So there's a very busy cross junction there. And if this cross junction is not functioning, then the nutrition state of the person is affected. So there are various ways to support the nutrition. So nutritional support starts with making the food textures safe and still palatable for patients. Then it goes on to maybe drinking and high energy, high protein supplement drinks to tube feeding. So hopefully we will get through some of these topics later. Then there's the all important thing about mobility, how you get from point A to point B. How you prevent pressure injury. So if I sit here for 4 hours without moving, I will have a pressure sore in my bottom. So of course I'm moving, And how do you help an ALS patient who is not so able to move to protect him or her from these injuries? Very importantly is communication. This morning with the doctors, I shared how I'm very annoyed every time I go to the ward and I see a head at the headboard of the patient. There'll usually be a name, the consultant doctor in charge. Then there's supposed to be a line that says language, but not uncommonly, I see the word uncommunicative. And I get very upset. I'll go and scold the doctor and nurse and say, "What is this uncommunicative?" Because unless you're in a state of coma, everybody can communicate. So if we can't communicate with the patient, it is the doctor and nurse's fault that we don't know how to use alternative methods. But as a patient or as a friend of an ALS patient, how do you optimize your communication? Are you satisfied with just communicating physical needs? Are you able to liberate the communication pathway so that judgments, opinions, and emotions can be clearly and rapidly exchanged? So some of you may have watched that very interesting video where Joe Biden, before he was president, he was still a candidate. He was interviewing an ALS patient in America. And that young gentleman was using an eye gaze tracker, but he had become so proficient using the eye gaze tracker that he was having a real-time conversation with the president candidate. So we have people in Singapore and in KL using eye gaze trackers. I think some of our patients are very proficient, but I'm not sure we have people who are so fast that they can do a conversation. So here is my challenge to those with motor neuron disease and your families. This is one area where it is very tough because it takes a lot of energy, concentration, perseverance. But I would say this is learning how to communicate, whether using modified ways to speak, using ways to write or type, using eye gaze trackers, or using letter charts. My challenge to you will be to try to optimize this. It may seem like, why are we wasting energy with this? But I think this is the number one thing that will make the quality of life of the people with ALS better. Because our dignity as human beings, our freedom, our autonomy is all tied to communication. I'm not an authority at all to talk about psychological or spiritual help. So I hope Dr. Loh has got some plans lined up there. And then the palliative people here would be very good at advising on making choices. So I was asking Dr. Loh what I should focus on, and then she said I should talk about breathing. So here we go. It may be very technical. I'm not used to talking to lay people. So if you can't follow, please stop me and then I'll try to go back. Okay. The important thing to note about breathing in people with motor neuron disease that usually it is not a lung problem. It only is a lung problem if you have been a chain smoker all your life, or you have had a series of lung infections that were not properly dealt with. You had many lung infections. Each time you have infection, then there's a bit of scarring, and after many infections, then your lungs are very destroyed. But if you have been looked after well, it usually takes many years before your lungs get diseased. But quite early in motor neuron disease, you may manifest with breathing problems, and it's because of the breathing muscles. So later in one of the neurology sessions, the neurologist will explain to you how motor neuron disease affects the nerves. But by affecting the nerves, it affects the muscles. So which muscles are we talking about? Of course, all of you know that we breathe in using the diaphragm. We breathe in using rib cage muscles and using our neck muscles. So these create a bigger space in the chest and then lowers the pressure and air comes in, right? Breathing out usually is by elastic recoil. So the lungs are like balloons, they will just push the air out. But now I'm talking to you, if I'm singing, if I'm coughing, then I need my breathing out muscles, my expiratory muscles, which are located at the rib cage and in the abdomen. So if these muscles are weak, you may not be able to breathe in properly. That may manifest either as shortness of breath in the daytime, which is not so common, or may manifest as waking up many times when you sleep. That is very common. Why will you wake up many times in the night when you sleep? Because when we sleep, we dream. So typically, we go through dream cycles once every 90 minutes or so. So at the peak of your dreams, when you dream of, you are the king of Malaysia or you are the emperor of Indonesia and you are leading an army to charge, if you act out your dream, then you may cause harm to yourself or your neighbor, your spouse, right? So our body is designed such that during the peak of our dreams, our body is actually half paralyzed. So if you are breathing poorly, your breathing muscles are weak, then you may find that during that time, the oxygen level in the brain drops, then you will suddenly wake up. Okay, so that is one of the most common manifestations which we ask in our clinic. And when you wake up, you will notice, hey, how come my shoulder a bit aching? How come I got a full bladder? Then you think you woke up because of the bladder, or you woke up because of the shoulder pain. But actually, you woke up because your oxygen level has dropped. And so it is very important for ALS patients to quit alcohol. I love my beer and my wine, but if I'm diagnosed with ALS, then I want to live on, I should stop drinking. Okay, because the alcohol and certain drugs affect the breathing control centers in the brain. It changes the carbon dioxide and oxygen thresholds, and therefore I may put myself at risk. Okay, so one manifestation is a disturbed sleep. Like I mentioned, if somehow your breathing muscles are inadequate even in the daytime, and especially because the diaphragm and the abdominal muscles support each other in holding the body up, some people may have shortness of breath when they're upright. Then that may be the presenting sign. For some people, it will present as a weak cough. They can't clear the phlegm. Then they present with either a kind of sensation of a lot of phlegm, choking with phlegm, or they may get frequent infections, and that could be how they present. The third will be actually a problem at the throat level. So this is our cross section of the body. So the nose, the mouth, the tongue. This is what we call the epiglottis. It's like a leaf. It's shaped to cover the vocal cords. This is where the vocal cords are. And then our esophagus or food pipe is behind. The trachea or windpipe is in front. So actually, when you want to swallow saliva, what happens is that your tongue pushes the saliva to the back. Your whole vocal cords will fold and close and rise. So all of you swallow now, and you find your Adam's apple rises, epiglottis folds down. So the saliva goes from the mouth into the esophagus. Conversely, when you inhale, air comes, okay, when you inhale, your diaphragm contracts, right? Rib cage muscle contract. Air comes from your nose, comes here, and actually at this point, your vocal cords will open. Epiglottis are raised, and air goes into your lungs. Okay, so this is a fabulous cross junction. So in Singapore, we got two main highways, PIE and CTE. And the junction of the PIE and CTE is a very busy traffic junction. I don't know in KL what is the equivalent cross junction. So, but if that is weak or uncoordinated, then you have a lot of problems. Your saliva or food going to the windpipe. You have phlegm here that cannot come out, cannot be spat out, and that is a problem. Okay, so this is the bulk of the problems I handle because of my training. Yeah, and I'm here to share this with you. Okay, so this picture kind of like explains what I've discussed in the previous slide. But essentially, why do we breathe? We breathe because we need to bring in enough oxygen for the body's needs. And we need to blow out some carbon dioxide, not all. We blow out some carbon dioxide so that we keep our blood acidity at the correct level. So the body has got certain needs, and over breathing, that means you breathe too much, is also bad. Under breathing is also bad. Okay, you under breathe, you probably will have low oxygen and you have a very acidic blood. You over breathe, you have enough oxygen, but your blood becomes very alkaline, and that affects certain organ performance also. Okay, so like we mentioned, this is how air gets in. What moves the air in is the pump. Okay, and then along the way, if you're a smoker or you've got asthma, you will have problems in the small airways. If you have heart failure, too much fluid and all that, or you have pneumonia, then you have problem with gas exchange in your lung air sacs. So we've got the video on breathing, which I think Dr. Lim Shu Xian played earlier. Y'all can have a look at it later. If you ever get admitted to hospital, you may hear doctors talk about type 1 and type 2 respiratory failure. What does it mean? It just means, is it the oxygen or is it a carbon dioxide that is causing problems? So type 1 is when the oxygen is low, okay? And this is usually because of a lung problem. So a lung problem or small airway problem, they have low oxygen, but the breathing muscles are strong, so you'll breathe more, and then end result, your low oxygen level and a fairly low carbon dioxide level. So this group, we will treat them with inhaled medicine, with oxygen, and with antibiotics and other drugs. If you have a pump problem, could be a brain problem, like let's say I've had a stroke in some part of the brain. It could be a spinal cord problem. It could be a muscle problem. Then you will end up with not enough breathing effort. So instead of shifting 5 to 7 liters of air in and out every minute, maybe I only shift out 2 liters of air in and out. Because of that, my carbon dioxide goes up, and then the carbon dioxide crowds out the oxygen in the lungs. Okay, so if that's the case, can you just give oxygen? You give oxygen, you will enrich the air in the lungs, but the carbon dioxide level may go up, 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 and if your body is not used to it, the acidity will kill you. The acidity will cause the heart rhythm and blood pressure to go off. Okay, so a lot of doctors are guilty of this. They oversimplify. Then they use inaccurate terms like, we use a ventilator to pump oxygen into your lungs. This is bullshit, right? And you read it in the newspapers and hear on the news, everyone says use ventilator to pump oxygen into your lungs. We are perpetuating a myth. I don't believe that you as patients or you as families cannot understand this. This is a fairly simple concept and the distinction is important. So a ventilator takes over your breathing muscles and pushes air in and out. Okay? Oxygen is something we give to enrich the air we breathe. Okay, so for you, for your own sake, for your loved one's sake, you need to get these two distinctions clear because you need to protect yourselves. So I hope that you all will take away from this. Today's lecture, you probably won't be able to remember everything, but there are resources out there which will be made available, and please avail of them. Okay, so if someone has ALS and comes to a sleep and breathing clinic for assessment, we will ask about all these questions. And then if you are a new ALS patient and you don't have breathing problems yet, look out for these problems. So we've mentioned the fractionated sleep, we mentioned the shortness of breath. Sometimes your carbon dioxide level is high, you may have headaches in the daytime. Just now, as we were starting, I was falling asleep, but that is probably post lunch. But if you are unnecessarily drowsy throughout the day, low energy level, that could be a reflection of the carbon dioxide levels. Some people will manifest as a change in mood or anxiety. Okay, so these are the questions that we ask in terms of symptoms. Okay, when you come to the sleep and breathing clinic, we will always do a blood test. So many of you fear the blood gas because it's an arterial puncture. We puncture either the groin or the wrist, and it's super painful because needle will hit the bone, right? And then it's very painful. Okay, so what we have done in Tan Tock Seng is that we have migrated to capillary blood gas. So it's a finger prick or ear prick. Okay, and this one we learned from the people in UK and France. It's much less painful. The problem with the capillary blood is that it doesn't tell you much about oxygen. It's not accurate, but it's accurate for carbon dioxide and it's accurate for the acidity. So for the purpose of looking at the breathing pump, The capillary blood gas, be it finger or ear, is good enough and it's less painful, okay, and allows us to monitor better. Overseas in Europe, they also do a overnight carbon dioxide monitoring attached to your skin. We don't do that routinely in Singapore is because it's too expensive. So it's called transcutaneous CO2. So that can be used to evaluate the sleep and breathing. So if any of y'all have very generous donors and want to donate equipment, that will be one good piece of equipment to donate to the clinic for use for patients who need sleep and breathing assessment. In Singapore, currently we have it in the sleep lab, so we don't do it at home. It's too expensive. Okay, then we do the lung function test, which is you will recognize is a blowing or sucking test. Most of the time, blowing. Okay, so the technician will ask you to take a big breath in and blow, 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 blow. So what happens is that you see this is the breath in. This horizontal axis is the volume. Vertical axis is the flow. You breathe in, then you blow out, blow, 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 blow. Okay, and if you are a smoker, we'll be looking at this part of the curve to see the pattern. But for ALS, we look at the height and the volume, the flow rate and the volume. Most importantly, the volume. So this chart shows you what is the predicted lung capacity or lung volume of this patient. So the predicted value is based on your age, your sex, and your height, because our lung size is affected by the height. Okay, so this gentleman has only got half the capacity of his predicted. He's after a maximal big breath in and a maximal blow, he is blowing 1.5 liters, whereas his predicted is about 3.3, right? Okay. So these are some of the tests that you will be asked to do when you come to a sleep and breathing clinic. So what is the big deal about the lung capacity? Actually, all of you are currently breathing like that now, small breaths, okay? I'm breathing a bit deeper because I'm talking loudly to you, trying to talk as loud as I can. Um, if I take a big breath in, then I blow. I'm doing this vital capacity. So normally the vital capacity, like in my case, should be about 4 liters, but my tidal volume is only about 400 mils. So there's a 10 times difference. When you have muscle weakness, the vital capacity will drop. As long as it is more than your tidal volume, your blood test will be normal. Okay, so as long as this is bigger than your tidal volume, your blood test will be normal. That's why we do not prescribe ventilator only based on blood tests. It's too late. Okay. Normally, most of the world guidelines will recommend that you can consider ventilation if you have symptoms. I mean, you can't sleep. If your vital capacity is 50% of the predicted vital capacity, or your blood test shows abnormalities. So usually, based on these three simple criteria, if you have one or two of them, then you can consider starting non-invasive ventilation. There are some centers that will recommend doing sleep study. A sleep study is good, but in most centers, you will find that the waiting time for sleep study is too long. And therefore, I've spoken to quite a few experts from Europe, US, and Canada. It's about half-half. Some of them will use sleep studies, like in France, in Paris. They've got a huge facility with 13 rooms for people to check in. Every night you can have 13 rooms, can do 13 sleep studies. So obviously the ALS patients will all be diagnosed that way. But in Canada, in UK, most of the time they don't have the facility to do a full sleep study. So they rely on the blowing test and on the blood test. Okay, so we talk about symptoms, we jump to the test. But if you're examining the patient, you may find that they're using their accessory muscles. So can you all see this? I'm pinching my nose. When I inhale, the whole chest is lifted up. This neck muscle is tense. So this is what we call use of accessory muscles. And if we use accessory muscles, often it is because the diaphragm is weak, and therefore you breathe like that. And this is a very inefficient way to breathe. You don't get enough. And a lot of patients will complain of headache because this neck muscles inserts to the base of the skull. So after a while, they will get headache from this effort, or they may get pain around here, right? So that is one clue that your breathing is not good if your accessory muscles are active all the time. Normally, these muscles should be relaxed and soft. Okay. The second clue is that when you're speaking, you start to need to catch a breath soon. Okay, so I hope I'm speaking to you in nice long sentences, but if I have breathing muscle weakness, I may start to speak in this pattern, and it will be very tiring. Okay, so you can quantify this by trying to take one breath and count, and you can use this to monitor your own progress. So 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21. Of course, it is not a very accurate way, but most studies show that about a count to 10 is more or less equal to a vital capacity of 1 liter. So, like for me, I should be able to count to about 35 or 40, which I can. So you can practice that, and then if you find that you're counting less, then time to get your vital capacity properly measured. The last thing we look at in physical examination is abnormal breathing pattern. So some of you may already know, like when the diaphragm contracts, right? When you breathe in, you see my tummy comes out and my hands will separate a little bit. This is a normal breathing pattern. But if you have diaphragm weakness, then the tummy may either not move or may even sink in when you inhale, and then the hands do not separate out. Instead, the whole chest will go up and down vertically because you're using your neck muscles to lift up the chest instead of expanding the rib cage like an umbrella. Okay, so these are some of the signs we look out for when we assess a patient in clinic. Of course, we look inside the mouth, look at the tongue, whether there are fasciculations. We ask them to swallow. We assess the quality of the voice and so on. Okay, I mentioned the blood test. So pulse oximetry is a simple, non-invasive way to check the oxygen level. Then the blood gas allows us to look at the carbon dioxide and pH. If you have access to a continuous pulse oximeter, you can run it through the night. So that is part of the formal sleep study, not the full study. Okay, you can run that through the night. I mentioned the night continuous carbon dioxide trend, which we don't do in our center, but is available in other places. Then of course the lung function test. So these are some of the assessments you'll be subjected to. Okay, at the end, the conclusion will be whether your breathing is normal or is abnormal. If it's normal, then what do you need to do? Nothing. If you have ALS but your breathing is normal, then all you need to do is to prevent getting lung infections. So how do you prevent getting lung infections? Wear a mask when you are around, So I think the mask wearing, which probably can continue beyond COVID, because it is quite protective against respiratory viruses. Get yourself vaccinated, so the flu and the pneumococcal vaccine will protect you from respiratory infections. Avoid going to crowded places where a lot of people, use hand rub and so on. So the common sense things. One special thing about preventive measures is flying, because you remember when we fly, actually the air at high altitude is thinner. So the cabin inside the plane cannot possibly be pressurized to the same pressure as sea level. So generally it's equivalent, pressurized to about 8,000 meters kind of equivalent, which means that the oxygen partial pressure in the air cabin is lower. So if you have ALS and you need to fly, it's better to some places like UK, they actually do a test where they do a hypoxic challenge test. But simple rule of thumb that people just pass around is this: break up your flights, take shorter flights, 2 to 3 hours, so that you don't need to sleep on the plane. Or if you need to, then and you're already using breathing support, then bring your non-invasive ventilator up the plane and use it during the flight. Okay, because the oxygen partial pressure there is lower. So by using the BiPAP, you make sure that you get enough kind of like breathing support. Okay. Okay, so that is prevention of infections, consideration for flights. Then now we come to what happens to help you maintain your lung health. So one of the problems is that we are not breathing enough. So our chest wall stiffens because every now and then we will take a sigh. When you take a sigh, your ribs open up with a big breath and it closes, right? When it opens up, there's a vacuum inside your chest. The lung pockets, the lung alveoli will all open. So if you don't take that deep breath every now and then, your ribs only go like that. Your alveoli, those that are open will stay open. Those that are collapsed will find it hard to open. So over time, it stiffens, and when it's stiff, it's hard to reopen. You all remember if you take a balloon, when the balloon is first collapsed, it's very hard to blow. After you have blown the balloon to a certain size, it's easier to expand, right? So preventing the lung collapse and preventing stiffening of the chest wall is necessary. It's 100% important for every ALS patient. So if you see a neurologist, they will tell you you need to do range of motion, prevent shoulder stiffness. You need to do knee range of motion, prevent your knee from stiffening. So for breathing, you need to do rib range of motion, prevent your rib from stiffening. Okay, so our subsequent sessions, there will be, I think physiotherapists will teach you how to do this, but essentially the commonly reported way to do it is what I call breath stacking, using a handbag. We stack breaths in to keep the chest open. So that is a cheap, easy, and effective measure. And with that, normally you will have an effective cough. If your cough is still weak, then you can breath stack, and then you can, okay? So these are some of the interventions that in our clinic we always teach. When we do home visits, we'll drill this into the patient and family. We will consider using breathing machines, non-invasive or invasive. We will consider artificial airway, and we may use another machine, a cough assist machine, to help clear secretions if needed. Okay, so this one is about restoring cough. So breath stacking, manually assisted cough, and cough assist. Later, I think Shu Xian will share the Tan Tock Seng home van YouTube videos. We have got 14 videos there, of which there are some videos on physiotherapy, postural drainage, but very importantly, some videos on breath stacking and cough assist. So please visit and have a look at them. So essentially, some of my patients tell me, I don't want to live like that, Why, I did have problems 9 months ago, now it's like that. So how do I encourage them? I'll say that, okay, look, now your legs are weak, so you can't walk properly on your own, but you're happy to use a walking frame. Or maybe you're happy to sit on a wheelchair. And with that, you can be mobile. So I say that breathing is the same. If you don't need, then don't use. Please don't use. Because if you don't need and you use, it just hastens your dependence. But if you need, so objectively, if you have fractionated sleep, you have got symptoms of shortness of breath, you have got abnormal blood test, abnormal blowing test, then you use the breathing machine to help you so that you can live life. It's a breathing crutch. Similarly, if you're choke full of phlegm, then you use either the breath stacking manually assisted cough or cough assist machine to help you clear your airways, and it's a coughing crutch. So all these equipment, they all serve one purpose. So a ventilator blows air into you. A cough assist helps you to clear your phlegm. On their own, they don't make you happy. Whether you're happy or miserable is up to you. Okay, but they help you to breathe, they help you to cough. The walking frame help you to walk. Wheelchair allows you to sit there and be pushed around. Okay, they will in a sense, make your life easier to some extent. They all cost money. So a tilt in space wheelchair costs much more than a canvas wheelchair. Life support ventilator costs much more than a simple BiPAP. Okay, they cost money, but they do that one thing. But so you have to decide, okay, do I need this? If I need this, do I want to use this and live with this, or I don't? In a sense, you have the choice, you have the freedom. But your decision should be, in a sense, guided by I know it's very tough to say this, because when we have an illness, we are all very conflicted. You have a lot of fears. You do not know what happened 3 months down the line or 3 years down the line. But your decision should be informed by a few factors. One is the scientific evidence tells you what this treatment can do for you and what will happen if you don't use it. That's one. The second is your own personal values and your priorities. And the third is the resources available to you. So if you are in a very poor village in Bangladesh, in border town in Myanmar, will you have access to a tilt in space wheelchair? No. You'll be lucky to have an improvised wheelchair that some kind neighbor made for you out of wood. Is that good enough if you have motor neuron disease? No, you will have broken skin in no time. But that is the best you can afford, right? So similarly, if you're staying in Singapore or Malaysia or Indonesia, it depends on your family situation. You may or may not be able to afford all these breathing equipment and so on. So I understand MND Malaysia is fundraising to help the poorer people to be able to afford treatments. Similarly, in Singapore, both government assistance as well as charity help our patients to access this. But ultimately, whether you choose to use these, I think it depends on your own circumstances. And then we do have many ways that we waste money. So you have to, together with your family, think through what's important. And I've got families who will spend a few $100,000, go to Panama or go to China for stem cell treatment, but they have no money to buy a ventilator, right? So I think there are priorities in how, even within medical treatment, there are priorities. And my advice to you will be to listen to the people in the mainstream and seek treatments that will help you, of course, in accordance with your personal values as well as the situation and circumstances in your family and society. So as professionals as well as volunteers, our job will be to advocate for ALS, try to make resources available, try to fundraise. We will give the rich people many opportunities to do good and have good karma or have treasures in heaven, so that the ones who are financially not so good need not worry about money. Okay, but whether we can definitely achieve that, I don't know. Okay, now we come to very quickly about non-invasive ventilation. So it's a machine that blows air at you, but the air comes into you either through a mask or nasal cushion. The mask could cover the nose or the nose and mouth. And it could be usually used only at night, but subsequently night and day. Why at night? Because of the dreams and our breathing insufficiency during the dreams. So non-invasive ventilation can have its side effect. If you wear the mask for too long, you will have broken skin on the bridge of the nose. For some people who have bulbar dysfunction, they may have more stomach bloating. For those whose vocal cords are very, very spastic, the vocal cords closed, there's a lot of pressure up here. They complain of ear and sinus discomfort. So not everybody will tolerate NIV, but when they do, it's very helpful. So this is a schematic picture from a medical journal. You have a fan that blows air. You have the interface. The air needs to get through the upper airway. That means your nose, mouth, throat. Okay, so there's some airway collapse here that it needs to get through. Then when the air gets into the lungs, it needs to overcome the lung stiffness as well as the chest wall stiffness. Okay, so meanwhile, the air will also leak. So there are some holes in the circuit or the mask it's called intentional leak. And then if the mask or interface doesn't fit well, it will leak from more places. So NIV is it's fairly intuitive. You look at it, you can understand. Then what we do when we set the machine is that we may choose different modes. So some modes will just give you X number of breaths, but more commonly the machine will sense what you're trying to do, and the machine will push the air. Okay, so the skill of the doctor or nurse is to adjust the machine. For you is to try to find the interface that fits you and then to use it. Okay. Okay, Mr. Wee is in the audience. I hope you don't mind, Mr. Wee. I'm using your picture and video. So, okay, we also have very big-hearted patients in Singapore. So, during the last New Year, our patients came together to offer New Year greetings. So, this is an exercise of advocacy for ALS and other home ventilated patients. Because also in Singapore, the community doesn't know the needs of this special group of people. And so we were inviting them to join us in a public exercise of awareness. So Mr. Wee gave this greeting.
Wishing everyone happiness, peace, and good health. Let us help one another. Let's pray for a better year 2021. To my caregiver, thank you for your care. I love you. You mean a lot to me. Thank you.
So thanks, Mr. Wee. And his last sentence is so important because actually his wife as well as his caregiver have made it possible for him to now focus on a bigger mission and bigger project, right? To do more things. Okay, but I was talking about non-invasive ventilation. So this is a nasal interface and it's nasal pillows or nasal cushions. So the advantage of a nasal interface is that you can see his mouth is open. He can use it to talk. He can use it to spit saliva, and he can use it to eat, right? So for ALS, we like our patients to start with a nasal interface if possible, because it gives them freedom for all this. And especially if your arms and legs are weak and you wear a interface that covers both the nose and mouth, we worry that when you go to sleep with it and you've got phlegm or saliva, you may end up choking. But not everybody can use a nasal interface. So for those whose jaw will drop or they have a lot of leak in the mouth, then it leads to a dry mouth and dry throat, or sometimes so much leak that the machine cannot cope with it, then bo bian, we may have to use an oral nasal. Okay, we usually will try nasal with a chin strap first. If it doesn't work, then we go to oral nasal. The nasal interfaces also tend to be a bit more expensive. So I know there are some countries in the world where, like, the government provides a device and they only give this. We are glad in Singapore we're not 100% dependent on government funding. So there are some charities that help to offset some of these for those patients who can't afford. Okay, we recommend that you have two different interfaces, because if you only have one, then if there are pressure sores, like if you use a nasal mask, you may get a pressure sore over here. If you use a oral nasal mask, some of them may have pressure sores here. Then it can be very tricky because the sore will not heal if you're wearing the mask all day. And you can't really choose if you really need the breathing machine. This is Mr. Fu, and he's greeting us.
Happy New Year.
Thanks, Lionel. Okay, so there are more subtleties about non-invasive ventilation. It can be a very powerful tool. There are many tips and tricks that we can use, but I won't cover them all today. But I'll go on to this, which is I think Dr. Loh Chin mentioned to me is a pressing concern to all of you. Okay, so I think the question of the tracheostomy, that there are a few special considerations here. So what is tracheostomy? Tracheostomy is simply this tube here in this picture. This tube here, it's inserted below the vocal cords. The vocal cords are here, and then it allows air in and allows air out. It may come with a balloon. If the balloon is here, is fixed, air can only move this way. If there's no balloon, then actually air can go in and air can leak out. Okay. So this is different from intubation. If now you get admitted to Tan Tock Seng Hospital and go to ICU, or you go to ICU, they will intubate you. What is intubate? Intubate, we open your mouth, put a plastic tube through here, over your tongue, under your epiglottis, through your vocal cords, into the lungs, into the windpipe. That is intubation. Okay? Tracheostomy is below the vocal cords. But the emergency rescue when you first come to ICU is always intubation. Intubation is awfully uncomfortable. It's terrible. Because those of you who remember, if you put a wooden spatula on the tongue, doctor asks, want to check your throat, asks you to say ah, right? The tongue depressor already caused a lot of gagging and discomfort. So can you imagine living with this tube here? So that's why most of the ICU patients need to be restrained or sedated or both. So like in Asia, I think we don't deeply sedate our patients, we restrain them, then they're always fighting. Then the family members will feel very sad, they go to ICU, visit a loved one, the patient is fighting. In America, they will bomb you out, throw a lot of drugs at you so that you're sleeping, so that you don't feel this tube. Okay, but anyway, the intubation, we can only keep this tube for 2 to 3 weeks. Otherwise, you have a lot of problems. So if we are admitted to ICU and we are hoping to live, often the doctors will say you need a trachea. Yes and no. Okay, so if you have motor neuron disease and is primarily affecting this area, we call it bulbar ALS, primarily affecting the vocal cords, the tongue, and the throat, then actually, yes, you need this tube to bypass for you to continue living. So I have had some patients who start is all near, you can't hear the noise, and then they are always choking on saliva. They have a lot of near misses where they are like in choking attacks, laryngospasm, very uncomfortable. Then when finally they are in and out of ICU, then we discuss, we do a trachea for them, we do a tracheostomy. Some of them actually can go around without a breathing machine for a few months. So they just need the artificial airway. They need to bypass this. I won't say this is very common. This is probably about 10 to 15% of the patients. Pure bulbar, the whole body is strong. Only this part is a traffic jam. So you bypass, you can get on with life for a few months without breathing machine. More commonly, we will have patients who have a trachea and they will need the breathing machine at night and some hours in the day. For some unknown reason, I don't know why, but a lot of patients with the trachea, if they put a breathing machine, they tend to use a breathing machine day and night, almost continuously. Whereas if you're on non-invasive ventilation, most of them stay on NIV mainly at night, and only a few use it day and night. Those who use it day and night is because the breathing muscles are the primary area of weakness. I suspect it's because when you do this, then it is so easy to allow breathing machine to blow air for you that it is very comfortable and it's a lot of effort to breathe on your own. So that's why patients end up being dependent faster. Whereas if you are using NIV, actually there's a little bit of discomfort using this. There's a bit of effort needed to guide the air. And so maybe some patients who don't need it will just use the NIV for some hours. Earlier, we talked about the acidity and alkaline status. If you are whole day using breathing machine, a lot of our patients end up being very alkaline. There are some side effects to it, but it's not easily preventable. So we have so far been tolerating the alkalosis. Okay, so we continue with tracheostomy. So there are two scenarios. One is if you go to ICU with a diagnosis of ALS, very likely you'll end up going home with a trachea because it takes a lot of skill, not just on the part of the doctor, but also the ICU team, the nurses, the physiotherapists, the respiratory therapists, to extubate you to non-invasive ventilation is challenging. We have done it for a few patients. We've done it for a few patients, but they are not motor neuron. They are people with like muscular dystrophy. Their vocal cord functions are better. Dr. John Buck has published a lot of papers about this topic, but most of his patients have muscular dystrophy and spinal cord injury. Most of his patients do not have ALS. So he also recognizes that if you have motor neuron disease and you have bulbar involvement, you may need the trachea, right? So that's one issue. The second issue is that, like in Singapore, certainly the ICU doctors and nurses are not skillful in this area of care. I'm not sure about KL, I'm not sure about Jakarta, but in Singapore, our ICU doctors are not skillful in this at all. After a while, the families of the patients with tracheostomy, they are much more skillful looking after the long-term ventilation. So, so this is one problem. So we often find that if you are admitted to ICU, you will end up using the trachea. This one, scenario 2, is what I mentioned, someone with a vocal cord problem that sometimes you just use it to bypass the vocal cords. Okay, so this patient was admitted to, not to Tan Tock Seng, but to Changi Hospital, but he went home and then we looked after him after he was discharged. And you can see because his was primarily a breathing problem, which led to a lung infection. He's actually still able to walk and to talk.
How are you feeling? So what did you do? You can walk.
I can walk, do around, like go to the toilet.
So this is a very good outcome for him because the ICU team in Changi Hospital were very motivated and they really pushed him for the rehab. So if any of you are admitted to the hospital, one of the dangers of hospitalization is you will just languish in bed. Do try, patient, family, try to cooperate with the therapist once your acute illness is not so bad, to try to exercise, to move, so that you will not be as dependent, as you will not be unnecessarily bedbound and dependent at the end of the hospitalization. This is another patient, Mr. Reese, who shows us how clearly his speech is.
Hey everyone, 2020 has been a tough year, especially so for us, the vulnerable ones. And to all my home ventilator users, hey, we've been through a lot, so stay strong, stay positive, and happy 2021.
So thank you, Reese, for the very positive, encouraging message. I apologize, I didn't mount the slide properly, so the picture disappeared when I show this when I show his speech. Okay, but he's got tracheostomy also, and there are ways to help a patient with tracheostomy to speak. Basically, remember I said as long as there's air leaking upwards, you can use it to talk. Okay, so you can borrow the air from the ventilator to make sounds. Okay, Dr. Loh wanted me to dwell a little bit on this point. So how to decide, should you go on non-invasive ventilation? Should you go on tracheostomy? I think there are various things. One is to know your own values, to know the resources available to you, and for that you have a composite decision making matrix. Okay, so for that, you need to know a little bit about what happens when motor neuron disease is advanced. Normally, by the time we are, well, this is not just motor neuron disease. If I get a stroke now and cannot move, I also need people to help me, right? Or if I've got advanced cancer and very weak, I need people to help me. So, but this is the most expensive part. For motor neuron disease, this is the most expensive part because you need 2 or more people to care for you when you cannot move. That is just to prevent the pressure source. Of course, if you have got a breathing problem, phlegm problem, you need to clear the airways. There's more work. But most of the work is just to turn you in bed, turn you in your wheelchair to prevent the pressure. If you're transferring you from wheelchair to bed, bed to wheelchair is very tough. So this is the most expensive part of care. All right, you will need a lot of equipment. So like the breathing equipment, in I won't talk about the cost because it's not transferable across the borders. In Singapore, when we started, one life support ventilator cost 15,000 Sing dollars. The price has come down to about 11,000 because there are now more people using it. So the market forces have pushed down the price. The cough assist, when I started this about 2011 2012, it cost about $7,800. Now it costs less than $6,000 in Singapore. So market forces can affect how much these devices cost. Of course, you use a simpler machine, it will be cheaper. Okay. So but breathing equipment in Singapore will tend to cost total about 15 to 20K if you buy. There are also ways to rent, and in our hospital now we are moving towards an equipment pool, a rental basis, but government subsidized. So we are always trying to see how we can lower this cost, but this cost is not the highest because there are ways to get around it. The most costly are the carers, because you either have family members who have to resign to look after you, or you need to have trained domestic helpers, or more expensively, you may have like trained nurses. So this is the most expensive care bit. But in Singapore, this is about 15 to 20K at the top end. Bottom end is about 3 to 5K. Okay. The hospital bed, pressure relief mattress, special wheelchair commode will cost a few $1,000s. Again, in Singapore, there's government subsidy for this. So not such a big problem. Um, if we are talking about Indonesia, Malaysia, then is it lobbying the government for subsidy, or is it a matter of fundraising from charities to provide this? And then lastly, the communication. When you need advanced communication tools, in Singapore, these cost about 10,000 Sing dollars. So again, we have got subsidy plus charity. So this is where I see that if MND Malaysia and ALS Indonesia, you can get traction from good-hearted philanthropists or companies, then we can solve some of these financial problems, and you may be able to have an easier time making the decision. So what is the ethics of making a decision? Are we obliged to seek every treatment? Is it wrong if I don't want treatment? I think that is deserves a discussion and a lecture all in itself. So I won't go into it here. Okay. So communication, I mentioned advanced tool like this is an eye gaze tracker, but simple tools could be a letter chart. Then you just scan the letters and then you just tap with your finger or thumb. So this was one of our patients. She had a little bell tied to her thumb, and she'll tap on the metal plate. So her family member will run through a letter chart in rows and columns. So they go down the rows first, then go across the column. And then when you reach the letter that she wants, she'll just tap and tap and tap. Okay, so this is how you can communicate. Even more basic for those who cannot use this kind, they can answer yes and no to questions. So it could be blinking, blink once for yes, blink two for no, or blink one yes, look to the side for no. So you can figure out how to communicate using various ways. And they are all quite they are all simple in concept, but they are difficult to use. You need to practice. So you need to fix on the method and practice with your team. Your team meaning your loved ones. So whole family and carers and so on. And then you may need to, like if you have friends visiting, you may need to have an information sheet for your friends so they know how to communicate with you. So if you work on this bit, which is very important, then you will be less isolated. You may find that you can still have a social life. You can still do things. Okay, we talked a little bit about survival. So we audited our whole group. So these are not all motor neuron disease. Only about 60% are motor neuron. The rest have spinal cord injury, various other diseases. But we are looking at our ventilated patients. And the median survival, that means the 50% mark. So of all the patients who go on to non-invasive ventilation, some still die within a few days, some die after 10 years. The 50% mark was 1.6 years. Those who go onto tracheostomy ventilation, the median, the 50% was about 3.7 years. So I use this information to share with my patients and family, and they have to use it to make decisions. Okay, so this was the publication. We didn't mention these numbers in this publication because for various editorial reasons, but what we have published in it is that for the ALS, the survival is drastically improved with ventilation compared with without ventilation. Okay, so when survival is prolonged, it is good because you have got more days around. So like I mentioned, the breathing machine does a job. It helps you to breathe. The cough machine helps you to cough, and they prolong your survival. Whether you are able to be happy, let's say you have 365 days more, are those 365 days going to be happy or going to be miserable? Do we know? So there are patterns internationally. I think the French have done a study on locked-in patients. Those who are tetraplegic can only blink and use eye gaze. They found that generally the satisfaction with life is about 60%. That means most of these people have suffering. They are not without suffering, but are able to accept the suffering, whether physical or psychological, and they are still happy they are about 60% happy. And they found that the predictors of happiness are that you can communicate and have some autonomy in your life. So with communication, then you can make choices. You can choose, okay, today I don't want to wear shirt, I want to wear t-shirt. All right, you can communicate that with your family member. The second thing is to have meaningful relationships. So if you have got meaningful relationships, it keeps you going. So this is the objective scientific study published in the French lock-in cohort, of which mainly is either brainstem stroke or ALS. Okay, our local data we haven't published yet, but we routinely touch in with the patients year on year. That means from the time you go home, then 1 year later, we'll check in with you. The social workers do a assessment, and we find that it's more or less the case. The patients themselves, the satisfaction is about 60%, and most of them are happy to carry on living. The caregivers, the family, because of financial stress, having to schedule, caregiver burden, not enough sleep, the family members tend to have about a 40% satisfaction. That means if my spouse were to have ALS, I expect the next 3 to 5 years to be not so happy. My spouse will probably be happy, about 60% happy, whereas I'll be about 40% happy. That's from Singapore data, not published. So you have to trust my word of mouth. But what we found is that we follow up with the family after the patient passed away. Most of the family members will find that they are happy that they walk with the patient and they make all the sacrifices. I just visited a wake this week. So one of our patients, she was on continuous non-invasive ventilation. She survived about 9 months in the home. So I spoke to the elder daughter, and she said to me, look, doc, my mom was a very outgoing person before ALS. She used to serve in church, visit a lot of other people, do a lot of things, and she didn't have time for us. So the last 8 months, we have her for ourselves. We, meaning herself plus her two sisters. So they have uninterrupted family time. So she said, yeah, it's true, it's tiring, it's stressful, but it is worth it. So I asked her whether I could share her story, So so these are the real facts that come with life support. So there's the nutritional support, there's breathing support. These two are the main life support in ALS. With them, you will live longer. You will get more days. Question is, what do you do with the days? So from the data out there, it seems like the patient should be okay if you can look after the physical needs, you can communicate, and you have meaningful social interaction. The caregivers will need a lot of help because of the high stress and burden. All right. So generally, yeah, we talk about a series of setbacks, a series of losses, but most patients, don't be alarmed if you yourself go through a period when you're suicidal. Don't be alarmed if your loved one goes through a period, because people need to go through that and then come out, okay? And what we seem to find is that eventually what makes them find acceptance is relationship. So love of a family member or love of the whole family, love of God, maybe a pet dog, and for some people it's a mission. So I'm very impressed. I mean, actually the MND Malaysia and ALS Indonesia are much more advanced than Singapore. You all have really so amazingly done this community mutual help. Singapore is just starting, but I've worked with a small number of our ALS patients, and I'm just so impressed at how life has changed. They have taken this mission on themselves. They've forgotten their own sufferings. Okay, so we can go through the difficulty. We can't choose our illnesses. I don't know whether I'll get ALS one day, or whether I'll get cancer or get heart attack or stroke. There's no point saying, "Oh, I wish I died in my sleep." If you really die in your sleep, your spouse or family may grieve like mad because they never had a chance to say goodbye to you. We can't choose our illness, but whatever comes, we make the best of it. Okay, so that's our collective experience. So what do you need to do if you have this new diagnosis? You will hear about it from a doctor. Some of us are not very good at communicating. We do not know how to break the news to you nicely. Okay, but please forgive us and try to accept the diagnosis. It's not easy. I don't know how you do it, but give yourself information, learn as much as you can. You will grieve. Okay, you will grieve the bad news of receiving the diagnosis. You will grieve every loss, a loss of a function, a loss of this, a loss of that. But remember that you are still unique human being. You're still a husband. You're still a father. You. I mentioned this friend. He's an engineer who built the Marina Barrage in Singapore. Okay, so that's the huge project where Singapore River and Kallang River feed into a common bay, and then they built a dam so that the flood waters can be contained. So when you have ALS, you don't stop being that person with so much contribution and value. And assuming you are somebody who has not lived a life with so much value, but you have 平平淡淡过一生, now you have ALS. Well, it's time for you to cherish every day and be very special. Okay, so you are still a special person. So you have to figure out how to find meaning and courage to face every day. You may feel that it's so humbling to now let your daughter clean you and feed you. Don't forget that you have fed her and cleaned her when she was a little girl. Now learn how to accept love from them. Okay? And for the caregivers, I really don't know how to give advice, because honestly, when we go around doing our home visits, we are just very humble at how they manage to do this, and they look after their loved ones. So I always tell them that you all are the best, you're the heroes, but go through it together with your loved ones. One day you will find that it's meaningful and it's okay and it's worth it. So it is worth it. the one advice I have for caregivers is to accept your imperfections. So don't hold too high a bar. Don't blame yourself. Nobody blame yourself for any illness of your loved one. Okay, because you already try your best. You didn't divorce your spouse. You didn't abandon your parents. You are there for them. So that is good enough. Okay, or if it's a friend, you know, you didn't abandon your friend. You are there. You're sacrificing, so forgive yourself even if you don't deliver perfect care. It is good enough. And then like Mr. Wee just now thank his caregivers. I think he was thanking both his wife and his helpers. For the patients, learn how to graciously accept the help and to appreciate and thank them. So I don't know whether I part with this picture of a movie, Life is Beautiful. I don't know whether you all have watched it. Actually, it's like a horror movie from beginning to end because it's about a Jewish man who he married a very brave, rich Italian girl who ran away from her family to marry him. Then after that, their whole life through the Holocaust. So being Jew, they were barred from work. The kid was ostracized in school. Then they were packed off to concentration camp, and every turn of the corner is a nightmare. And this guy never stopped looking on the bright side. In the concentration camp, he managed to find a way to broadcast his love for his wife, and he made his final moment in life a joke and a story that his son remembers forever. If you haven't watched this movie, please go and watch it. So I share this with all my ALS patients. I say, you know, life is not easy, but life can be beautiful. Okay, that's all I have.